H. pylori. H. pylori belongs to the group of pathogens within the enteric tract known for gastritis and peptic ulcer. Starting with its characteristics, let's see. It has helix shape, motile as it uses its flagella to propel around stomach, and most importantly, it is a curved gram-negative rod. A short review for gram staining. We take a specimen, heat the stride to fixate the bacteria to stride, and then, as you see below, first the application of crystal violet stain which gets sucked in the peptidoglycan layer, keeping in mind that gram-negative have a thin peptidoglycan layer as compared to gram-positive, which stains darker. Next, we apply mordant iodine, which locks the crystal violet in the peptidoglycan layer. Next is ethanol wash for washing some crystal violet off the layer. Then we have safranin, a counter stain that soaks in peptidoglycan layer where crystal violet is absent. So we know gram-negative stain pink. That's it. Let me know in the comment section if you want a detailed video. Now moving on, H. pylori are urease positive, that is, they release an enzyme urease that splits urea into ammonia and carbon dioxide to reduce acidity and provide suitable environment for bacteria, and serves as a screening test as well. In urea breath test, the patient swallows urea with radioactive carbon, and if the organism is present, urea will be cleaved and radio-labeled carbon dioxide is evolved and detected when exhaled. Okay, so next, H. pylori is also oxidase positive, as due to presence of enzyme cytochrome oxidase on exposure to air, it stains dark blue to purple in 30 seconds. Lastly, we also know it is transmitted by ingestion. Moving on towards pathogenesis. The H. pylori attaches to mucus-secreting cells of gastric mucosa. The ammonia produced by action of urease plus the inflammation damages the mucosa. Chronic infection causes increased acid production by reducing somatostatin or increased gastrin production, coupled with loss of protective mucosa cause ulcers. Most common are duodenal ulcers. If untreated, creates risk for gastric adenocarcinoma. It is also linked to mucosa-associated lymphoid tissue lymphoma in stomach or other areas which goes away after treatment. Now on to the clinicals. The patient experiences recurrent pain in upper abdomen which worsens on empty stomach, bleeding in GIT, nausea, loss of appetite, frequent burping, bloating, and unintentional weight loss. Next, we have laboratory diagnosis. First, there is urea breath test, which we have discussed earlier. Second, we have presence of H. pylori in biopsy specimens and gastric epithelium during endoscopy. Third is stool test, and then there is presence of immunoglobulin G antibodies in the serum indicating infection. Lastly, we have treatment in the form of triple therapy, which includes proton pump inhibitor to counter increased gastric acid secretion and antimicrobials amoxicillin and macrolide. So, this is it.